Greetings, colleagues from Bulgaria. This is Dr. Lukan Mishev. I work in Focus Eye Clinic. I specialize cataract, vitreal and glaucoma surgery. And thank you for having me here. Especially I want to thank to Professor Milton Yogi for inviting me to participate in this academy. Here is one case on which we'll implant a toric lens. These are the markings which are preoperatively measured. I will use a new device called Robomarker, which is gravity aligned with pendulum. The main difference is that there is a light on which the patient can gaze during the marking process, so it's a possibly mark on the visual axis. The marking is the same as the previous devices, but it is one-step marking, so the space for mistake is only once, not 2 times as before. The tips are extended, they are single use, and they are pre-inked, sterile, so everything is pretty straightforward. You can choose between blinking light, continuous white, or changing color continuous light. These are our tables. We use 2 cc syringes for hydration and hydrodissection, 5 cc syringe for irrigation of conjunctiva and cornea during the operation, 2 types of visco, cohesive one and metallocellulose. This is the tray for autoclaving the instruments. There are tissues, and the cover of the table is single use, of course. This is a side port knife 1.2. Normally I do 2 side port incisions, which are on 3 and 9 o'clock. These are the markings. Now I will put the viscoelastic, which is cohesive viscoelastic. I like the AC to be firm and good filled in order to be able to perform a safe capsulorhexis. Most important thing for me is that I create the main incision, which is 2.2, after I fill the anterior chamber, so I get a stable cornea and nice construction of the corneal incision. Now with Utrata forceps, I pinch the capsule, then I lead the rhexis clockwise fashion. Important thing is do not tear, just pull the rhexis flap in order to control it better. Now the hydrodissection, I do it in 3 and 9 o'clock with 27 gauge cannula, 2 cc syringe. Now I screw the tip of the handpiece, which is Ozil. I prefer to use balanced tip from Centurion. The machine which I use is Constellation. The tip is already screwed. This is the sleeve, which is important to be the sleeve for balanced tip. The chopper is Mayoshi for right-handed surgeon. So my technique is horizontal chop. I like to use moderate vacuum 2.80, flow rate fixed 14, the vacuum is linear, longitudinal Phaco is 0, torsional is 40, 45, and the bottle height is 115. Bear in mind that the Constellation there is no bottle height. The bottle is constantly pressurized There is no IOP control, although for anterior segment surgery. The IOP control is only valid for vitreoretinal surgery. Here are the pieces. Exceptional followability from this tip. It do not clogs, and there is no need for IP or some longitudinal bursts. Here is my staff paying attention during the surgery. Okay, again the specs. Now I'm with bimanual irrigation aspiration. I like this because I control the movement of the eye during that procedure, and there is no space which I cannot reach during the irrigation aspiration. I meticulously clean the cortical materials, and if anything is left there, because I believe that the capsule should be clean. You can switch the handsaw, of course, and take care for the next part of the capsule. Here is the lens, a toric lens from Lentis, which is custom made because the patient was highly myopic. The diopter is 2.83 sphere with 428 diopter cylinder. Now, after cleaning the capsule, we will prepare the anterior chamber. My specs for INA are 280 vacuum, 17 linear flow rate, and 91 bottle height. Here is the end of it. My assistant is prepared with the viscoelastic. In this case, I will use metal cellulose, maybe. You see the shield, which is transparent. We normally patch the eye with shield, not with tissue. And now I will put the viscoelastic, which is metal cellulose. The assistant is already prepared with the cartridge. I prefer to put viscoelastic by myself inside the cartridge. Now the lens. Normally I look under the microscope the orientation of the lens, then I put it in the cartridge, close the cartridge, and use the single-use injector. I use a spatula during implantation to stabilize the globe because I use wound-assisted technique, and this is the implantation. Now I will use a spatula and Lester or push-pull manipulator to maneuver the lens on the needed position according to the markings. After that, there will be an irrigation aspiration of the viscoelastic. And wound hydration. In the end, we don't use any intracameral antibiotic or subconj antibiotic or dexamethasone we just use antibiotic drops and steroid drops. Then we patch the eye with clear, transparent plastic cover. And that's it. Here are the drops. We remove the speculum after putting the drops.